Hi, welcome to our Pharmacology Project. This is about treatment for heart failure. So what is heart failure? Heart failure occurs when the ventricles of the heart are unable to pump a sufficient amount of blood to meet the body's metabolic demands. Heart failure can happen on the left, right, or both sides of the heart. With left-sided heart failure, congestive heart failure, blood accumulates in the left ventricle. Hypertrophy of the left ventricle occurs as a result of the increased workload, and over time the myocardial cells die. Blood eventually backs up into the lungs and results in symptoms such as shortness of breath, coughing, and coughing. Left-sided heart failure can further be classified as systolic or diastolic. In systolic heart failure, the ventricles are unable to pump enough blood to the body. Diastolic heart failure is an inability for the heart to relax in between beats, which causes a backup of blood into the heart's chamber and blood vessels. In right-sided heart failure, which is less common, blood backs up into the veins and causing a peripheral edema and engorgement of certain organs. Here is a diagram of the heart during systolic and diastolic dysfunctions. So causes and symptoms. Heart failure can have many causes, and some of them include aging, coronary artery disease, mitral stenosis, myocardial infarction, myocarditis, pulmonary hypertension, chronic hypertension, diabetes mellitus, hypothyroidism, and hyperthyroidism. With heart failure, you can experience several different symptoms as well. These include shortness of breath, fatigue, weakness, swollen jugular veins, abnormal swelling from fluid buildup, pedal edema, and heart palpitations. Diagnostic testing includes chest X-rays to look for cardiomyopathy, pulmonary edema, or pleural effusion. An electrocardiogram or echocardiogram are other common diagnostic tests. This slide includes some interesting statistics about heart failure in the U.S. For example, the number of adults living with heart failure increased from 5.7 million in the years of 2009 to 2012 to 6.5 million from the years of 2011 to 2014. This statistic is projected to rise at least 46% by 2030. Equally, at least 8 million adults who will be living with heart failure. These statistics are frightening, as they account for only the adults in the U.S. and no other population worldwide. And you will see the map of the U.S. and its death rates by state and county. Heart failure is considered a preventable condition. Lifestyle modifications to prevent or control heart failure include smoking cessation, losing or maintaining weight, avoiding alcohol and caffeine, eating a diet low in fat, cholesterol, and sodium, appropriate stress management, exercising regularly, and managing underlying conditions such as hypertension, diabetes, and hyperlipidemia. Another option for recovering from heart failure is cardiac rehabilitation. If heart failure is severe, surgery or implanted devices may be necessary. These include implantable ICD, CRT, LVAD, angioplasty, coronary artery bypass, valve replacement, or heart transplantation. There are several different classes of drugs used to treat heart failure, and some of these include ACE inhibitors, angiotensin II receptor blockers, also known as ARBs, diuretics, beta-adrenergic blockers, direct vasodilators, cardiac glycosides, phosphodiesterase inhibitors. Now I'm going to explain to you the pharmacotherapy of these different classes. For ACE inhibitors, they lower peripheral resistance, inhibit aldosterone secretion, and dilate veins. Cardiac output improves, pulmonary congestion and peripheral edema diminish, and cardiac workload is decreased. For ARBs, they block receptors for angiotensin II in the atrial smooth muscle and adrenal gland and cause blood pressure to fall. For the diuretics, they reduce fluid volume and lower blood pressure which decreases workload on heart and improves cardiac output. For the beta blockers, they block the cardiac actions of sympathetic nervous system, which slows heart rate and lowers the blood pressure. For the vasodilators, these directly relax blood vessels and lower blood pressure. For the cardiac glycosides such as digoxin, it causes the heart to beat more forcefully and slower, which improves cardiac output. And for lastly, the phosphodiesterase inhibitors, these increase the amount of calcium available for myocardial contraction. Cardiac output improves due to the increase of contractility and decreases in the afterload. Now we're going to get into examples of these heart failure drugs. To start off with ACE inhibitors, an ACE inhibitor is lisinopril. For lisinopril, you want to give a dosage for heart failure between 10 to 40 milligrams a day, and it has a half-life around 12 hours, so it's optimal for once-day dosing. Common adverse effects include cough, headache, dizziness, hyperkalemia, and rash. Angioedema is a serious adverse effect that needs to be monitored as well. Nursing considerations for this medication is to assess the blood pressure and pulse prior to administration. You want to hold the dose if the pulse is less than 60 beats per minute. You want to monitor the first dose phenomenon where blood pressure may drop substantially. And also monitor elderly patients as they are at an increased risk for falls. Next is the angiotensin II receptor blockers, losartan. For losartan, you want to give this to patients who are unable to tolerate the adverse effects of ACE inhibitors, and the dosage ranges from 5 milligrams to 40 milligrams maximum and is increased as tolerated. A couple of things that you need to know about this medication is that you should not take it during pregnancy due to fetal injury, and you want to avoid concurrent use of potassium-sparing diuretics due to the risk of hyperkalemia. Again, nursing considerations are the same. You want to assess the blood pressure and pulse prior to administration and hold the dose if pulse is below 60 beats per minute. You want to monitor first dose phenomenon where blood pressure may drop substantially, and also monitor elderly patients as they are at risk for increase of falls. Lasix is an example of a diuretic. For this medication, you want to have a dose range from 20 milligrams to 80 milligrams once or twice daily, and it removes a large amounts of urine in a short period of time. So adverse effects would include electrolyte imbalances, focusing on hypokalemia, dehydration, and hypotension. Ototoxicity is a serious adverse effect, and you should call your doctor. Nursing considerations would be to check the patient's serum potassium levels prior to administration. If it is low, notify the provider before administering. You want to monitor vital signs for evidence of hypotension or dehydration, electrolyte imbalances. Metoprolol is a beta-adrenergic blocker. For this medication, the dosage is 12.5 milligrams or 25 milligrams once a day due to prolonged half-life. With this medication, you want to avoid the use of alcohol due to additive hypotension. It may mask the signs of hypoglycemia in diabetic patients, and the adverse effects include hypotension, fatigue, abnormal sexual dysfunction, and insomnia. For nursing considerations, you want to assess the blood pressure prior to administration. If the pulse is less than 60 beats per minute or hypotensive, hold the dose. Monitor the elderly as they are increased risk for falls. Bidil is a vasodilator. It is dosed at 20 milligrams of isosabide and 37.5 milligrams of hydrolyzine, and is taken 2 to 3 times a day due to short half-life. Dosage require adjustment as tolerance develops after a couple months. Adverse effects of this drug include reflex tachycardia, headache, flushing, palpitations, and a lupus-like syndrome that may develop after 6 months. Nursing considerations for this medication would be to educate the patient not to abruptly discontinue this, as it may cause rebound hypertension and anxiety. Continue to monitor vital signs. Digoxin falls under the cardiac glycoside class. The dosage is 3.4 to 5.1 mcg/kg once a day. Due to narrow margin of safety, adverse effects are serious and include dysrhythmias due to hypokalemia, visual disturbances, nausea, vomiting, and anorexia. Hypokalemia may occur with concurrent use of diuretics. ACE inhibitors can cause hyperkalemia and decreases effects of digoxin. Use with beta blockers may cause bradycardia. Nursing considerations would be to take an apical pulse for 1 minute prior to administering. If less than 60 beats per minute, hold dose. Check serum digoxin level prior to administering due to risk for toxicity, and hold the dose if it is higher than 1.8. Monitor for signs of digoxin toxicity. And lastly, there's Primacor, which is a phosphodiesterase inhibitor. It has a short half-life and a rapid onset of action, within 2 to 10 minutes via IV administration. The dose ranges from 0.25 to 0.75 micrograms a minute. Adverse effects include headache, nausea, and vomiting. Ventricular dysrhythmias is a serious adverse effect and occurs in 1 out of every 10 patients. For nursing considerations, you want to monitor the ECG and blood pressure continuously during infusion for dysrhythmias and hypotension. There are many factors you want to teach your patients who are on these medications. Some big ones are daily weight monitoring, signs and symptoms of decompensation, medication, physical activity, sexual activity, diet, and social life. And that brings us to the end. Thank you for listening.